All right, let's jump right into this explainer. I want you to literally picture me as your attending physician right now. We're going to do a rapid-fire, really high-yield review of head and neck oncology. We'll be mapping out those crucial intersections where pathology meets human anatomy, the stuff you absolutely have to know.
Here's our roadmap for today. We've got 5 stops: the oral cavity and oropharynx, the nasopharynx and sinonasal tract, the laryngeal zones, salivary gland malignancies, and finally, neck dissections and lymphatics. Let's get to it.
Kicking things off with Section 1, the oral cavity and oropharynx, focusing on those critical surgical thresholds.
So, let's start with a classic, and I mean literally textbook, board-style presentation. Think about it. Where exactly is the tumor hiding when your initial clinical exam shows absolutely nothing, but the patient comes in with a metastatic level 2 mass in their neck?
The answer? The oropharynx. More specifically, we're talking about those deep crypts of the palatine tonsils and the base of the tongue. Now here is a massive, high-yield exam pearl for you. We actually use the P16 protein as a surrogate marker to look for transcriptionally active high-risk HPV. And this is huge. It's an absolute game-changer because P16-positive tumors respond so remarkably well to therapy that they literally get their own downstage classification system.
Now, let's say we do find a primary lesion, right? Something like an oral tongue squamous cell carcinoma. You've got to burn these 2 golden surgical numbers into your brain. First up, gross margins. You absolutely must take 1 to 1.5 centimeter gross clinical margins. You might be wondering why so massive. Well, it's because tissue shrinks. It shrinks by up to 30 to 50% after you excise and fix it, and you need a final clear margin of at least 5 millimeters. Second number, always check the depth of invasion, or DOI. Once that depth tips past 4 millimeters, the risk of occult microscopic metastases to the neck shoots past 20%. And that right there is what triggers the need for an elective neck dissection.
And hey, we really can't leave the oral cavity without talking about field cancerization. It's exactly what it sounds like. Chronic exposure to carcinogens, like tobacco smoke, doesn't just damage one isolated spot. Instead, it creates these widespread, diffuse pre-malignant genetic alterations across the entire mucosal field. It's like a bad seed spreading. This perfectly explains why these patients face this relentless 3 to 5% annual risk for developing a second primary tumor. And honestly, it's exactly why they need lifelong monitoring.
Moving right along to Section 2, the nasopharynx and sinonasal tract. Let's talk about skull-base cancers.
Okay, here's another great scenario for you. You've got a 48-year-old Asian female presenting with unilateral hearing loss, recurrent nosebleeds, and a progressive posterior nasal cavity mass that biopsies as non-keratinizing carcinoma. You should immediately be thinking of one very specific viral driver. Do you know which one?
Yep, it's the Epstein-Barr virus, or EBV. It completely drives these nasopharyngeal cancers. And what's wild is, unlike most head and neck tumors, we actually manage these primarily with definitive radiation or chemoradiation. Why? Because the deep anatomy there is surgically inaccessible, and luckily, those cells are exquisitely radiosensitive. Now, on the flip side, if we look at the sinonasal tract, squamous cell carcinoma is the main culprit. But these guys are incredibly stealthy. They literally hide out in those air-filled cavities, totally mimicking chronic sinusitis, and they usually only present at a really advanced stage, usually after they've already started destroying bone.
All right, down into the airway we go. Section 3, the laryngeal zones, where anatomy truly dictates destiny.
So, think about the 3 distinct zones of the larynx. Which subsite has the most abundant, dense lymphatic drainage? The one that basically acts like an absolute superhighway for cancer cells, leading to sky-high rates of bilateral cervical metastases.
It's the supraglottis. It has this remarkably dense lymphatic network, which unfortunately means 40 to 50% of these patients are going to present with nodal metastases right out of the gate at diagnosis. But contrast that drastically with the glottis, the true vocal cords. The glottis has virtually 0 lymphatics. Because that drainage is so incredibly sparse, the metastasis rate is super low. And that's amazing for us, because it allows us to cure early-stage glottic cancer with just isolated radiation or a transoral laser excision. The absolute best part? We get to successfully preserve the patient's voice.
Let's step out laterally for Section 4, salivary gland malignancies and lateral neck pathology.
Here's your next question. Which primary malignant salivary gland tumor might grow really slowly, like very indolent in the short term, but is absolutely notorious for its relentless affinity for perineural invasion? You know, the one that uses the body's neural wiring as a highway straight to the lungs?
That would be adenoid cystic carcinoma, or ACC. The crucial takeaway here is that ACC is the ultimate infiltrator. It's notorious for tracking along nerve sheaths way beyond the palpable mass. You might feel a small lump, but underneath, it's quietly spreading along those nerves. Because of this, it demands immense clinical vigilance and sadly carries a pretty poor long-term prognosis.
And hey, speaking of nerves, let's talk surgical pearls. If you're doing a parotidectomy, say you're just removing a benign pleomorphic adenoma from the superficial lobe, you have to guard the temporal or frontal branch of the facial nerve at the superior margin with your life. If you accidentally injure that branch as it crosses the zygomatic arch, your patient is going to completely lose the ability to wrinkle their forehead or raise their eyebrow. Definitely not an outcome you want.
All right, final round. Section 5, neck dissections and clearing those lymphatics.
Time to really test your definitive surgical anatomy. During a formal classic radical neck dissection, which 3 specific non-lymphatic structures absolutely must be explicitly sacrificed?
For it to be a true classic radical neck dissection, you have to sacrifice the sternocleidomastoid muscle, the internal jugular vein, and the spinal accessory nerve. That's cranial nerve 11. Now contrast that with a modified radical neck dissection. You're still clearing out the exact same lymph node levels, 1 through 5, but you're deliberately preserving at least one of those 3 structures. In practice, we almost always try to spare that spinal accessory nerve to save the patient from the severe shoulder drop and physical dysfunction that comes with losing it.
Okay, picture this. You're dissecting low down in the neck, clearing out levels 4 and 5. You spot a nerve traveling vertically, resting perfectly flat on the superficial surface of the anterior scalene muscle. What exactly happens if you accidentally transect it?
Well, you'd end up paralyzing the patient's diaphragm. That is the phrenic nerve, derived from C3 to C5. It provides exclusive motor innervation to the diaphragm, so putting it causes ipsilateral diaphragmatic paralysis and an elevated hemidiaphragm. Okay, shifting gears from lateral structures back to the lower midline, let's look at one final anatomical pearl for lymphatic flow.
You always need to anticipate lymphatic flow. For instance, the cervical esophagus preferentially drains straight to level 6, the central compartment. Midline esophageal tumors are basically going to target that level 6 compartment first, draining right into those paratracheal chains long before they ever start tracking laterally out to the deep jugular nodes.
To wrap things up, the big takeaway here is this. Mastery of head and neck oncology is not just about memorizing pathology. It's about mastering the map of human anatomy. The two are inextricably linked. So, armed with this structural map, I've got to ask, which anatomical zone are you going to review next? Keep exploring, keep questioning, and I'll see you in the next explainer.